Modern epidemiological analysis has diverted from traditional epidemiological analysis in much the same way that modern traffic science has diverted from traditional traffic science, in the sense that historically epidemiological systems were based on a mathematics of well-mixed systems. They were differential equations, and they were coupled rate equations, actually, and you would tune them, and they would tell you about average properties of populations of similar interacting things. And they were incredibly useful. They still are, and that's what's traditionally used. But what's happened in the last decade or so is a movement toward what is called social epidemiology. It's computational. It is at the individual level, or at least a much more disaggregated form than the traditional ones. And it's led very naturally to, for example, extremely large graphs in networks. So if you have hundreds of millions of people interacting, and you use an edge, and you use the people as vertices and the edges as indicators of the interactions, and you wind up with these, 10 to the 15th, 10 to the 18th, 10 to the 20th edges, sizes, graphs, and you have to figure out what to do with them, and it relates then to very large computing. So what I'm going to call that is not social epidemiology, because I think that's a confusing thing to call it. But what I will say is that it is epidemiology, especially with respect to infectious diseases, that takes into consideration social determinants. And the social determinants of epidemiology are extremely important, and I'll just give one example. I won't go into a lot of detail except to say that in the Ebola crisis in West Africa, the entire crisis was mitigated and shut down with social interventions. There was never a pharmaceutical intervention. There was never a medical intervention of the kind that you might imagine. It had to do with changing funerary processes and certain kinds of mobilities and other kinds of behavioral things on the part of people, and convincing them to do it and convincing them to do certain kinds of things. And once their interactions changed, then the epidemic was mitigated. And so I just want to say that handling social determinants is more than simply some funny thing to do because you want to model everything and so on. It's deeply significant, but it does lead to these very large calculations. Now, in the 10 years or so, or 15, depends on how you look at it, that this has sort of been going on, the same thing has happened. Several things have happened. One is that in bioinformatics, we've gone through this commoditization of bioinformatics, so the sequencing of bacterial and viral genomes has just gone on apace. You can identify things in ways that you couldn't do before. It's connected into the whole system in ways that are pretty hard to imagine, even 20 years ago. Only in 2007 to 2009 did we get into this high throughput sequencing regime, and that is going apace to the point that in the nanopore technology, which is still not fully in hand, but the nanopore technology has little things about the size of these dongles that fit on the side of a laptop, and they will allow millions, maybe even billions of reads to be done in ways that you can imagine commoditized processes for perhaps a parent that wants to know if their child has a strep or not, that they can actually do a sequence analysis on their own phone. It's an incredibly rapid movement of the way data is, so there's nothing slowing down the tendency towards an ICT-enabled, social, substrate-driven view of infectious disease and other disease for that matter. But it means that the computing is being pushed out. It's what we were talking about before, and it's the reason I changed this talk. So I'm going to just go, so I called it Rethinking Extreme Scale Epidemic Analysis. And so basically what I just said, increasing interdependence and coupling between biological and socio-technical systems is ongoing, which I won't go into, but the ICT advances imply qualitative changes, not just quantitative changes in the amount of computing. They make you do things differently than you did before. And so we start out being people with our stuff, and we have an IoT sort of view of ourselves, and we wind up being people in vertices with properties and a bunch of unstructured meshes that, not just one unstructured mesh, but many, many unstructured meshes that characterize us and that the data full detail, activity locations, people, not scripted, calculating interventions and figuring out, so we can turn these things around in matters of seconds, which means we can do very large counterfactual experiments. We can support decision making. It's becoming reasonable, and it's being done at full scale, every individual represented. Oops, the graphs and networks, the encapsulation are what they mean is being rethought, but they're central. Encapsulation metaphor in software is passing in the sense that the usual idea of a giant monolithic simulation is passing. We're into big multipartite graphs connecting properties organized around individuals. We're computing on data-centric platforms. There's application ecologies that ride on them. There's multiple specific parallelizations that are possible all over the place in the system, not just at a computing center someplace. And it informs how to connect all this stuff, and how to do it together informs HPC architectures. And basically it's been driven by this problem, is that everybody wants to make pervasive, real-time, and personalized decisions. They want to know how many kids in my kid's school have the flu today. If I send my kid to school today, it isn't just the public health officer that wants to know that. Everybody wants to know that. Everybody wants to know if they're going to go on vacation in Florida, where is the Zika neighborhood? Everybody wants to know that as much as they want to know what the weather's going to be like. And those kinds of, and they want to know how to route themselves to avoid congestion, and they want to know lots of things, how to get the best price on a hotel room. All of these things are personalized services that come from a pervasive, ubiquitous environment that provides social determinants of behaviors that lead to diseases. And this is what I was, and also purchases and lots of other things. They lead to lots of things. This is a couple years old now. The extreme scale, spatial temporal network, everything, causal models, they're already here. We don't have to wait to see if maybe we can do this. We have national scale simulations in the United States, 300 million node graphs, 15 billion interactions, running on 350,000 cores in 10 seconds. And actually, this is running on 700,000 cores in less than 10 seconds now. And we think that with other, we're not even trying to work on scaling. All we're doing is measuring the scaling capacities of the system. If we were actually worked on it, and this is much more relevant to us than like a LINPACK test. This is nothing to do with LINPACK. This is how fast these simulations run. And it means that we can do lots and lots of them. It means that you can provide on a service basis access to the data generated by these things for all kinds of decision makers, public health officials, mothers and fathers, and so on. The basic global synthetic human information library is an index system. It's basically the structure of the library system. It's the card catalog of the system. It has a lot of information in it, but not the whole book, right? It's about 2 gigabytes per million people. It takes 8 terabytes to store it. It takes about 5 days to completely update it. And this is a structured data library for every person on the planet and every activity location on the planet. And the point of this is that this is obviously provisional knowledge. This is knowledge that's continuously changing. And so it has to be continuously dealt with. So there's a pipeline associated with it, and what you even mean by these data records is subtle, and I won't go into it now. So HPC is necessary for scaling like this, but it may not be what you think it is. I mean, there are, of course, the rooms like you see in these pictures, but the abstractions matter because what we implement and how we think about it is affected by the abstractions. The data and network-centric architectures and approaches matter. Pervasive services are we have to connect to all these ubiquitous computers. This pervasive computing has to become part of our view of what these computers are. Parallelism has to be exploited wherever it occurs. We don't organize it in one simulation in some model on an HPC machine. It's occurring all over the place. The equivalent of what is now being called fogs and mist, it's unfortunate. The whole cloud paradigm needs to evolve and grow so that parallelism is dealt with in a distributed fashion, and people and things are interacting, really interacting through the ICT Interactum. This is not virtual, these are actual interactions. So who is it that needs all these HPC needing, who are all these HPC needing decision makers? Who are these people? Is it, as Rob said, this person with millions of dollars in sunk cost and hundreds of billions of dollars in risk associated with their decisions, and they're cautious and won't buy into new things? Are they the ones we're focused on? I don't think so. I think this is who needs it. Everybody needs it. And I think that's the direction, and that's the reason that we're going, and that's the reason we need to rethink what we mean by HPC in epidemiology.